Okay, I'll kick off. So welcome everyone to our seventh of seven Innovator Toolkit series webinars. This one is about developing NHS business case, so hopefully you're in the right place. If you've been on previous ones, I'll do a little introduction to who we are and what we do, and then get into the main content. I should introduce myself. I'm Matthew Lawrence, Head of Industry and Innovation here at Health Innovation, Oxford and Thames Valley, and really happy to see everybody. For people who've joined before, welcome back again. For those who are new to this, welcome. You can find all of them on our website. I will share that later on. So here you go. These are the 7 that we've done. This is the 7th one, that one at the bottom in kind of orange. We've done all these different kind of webinars which are available as videos. And if you've joined, you get the slides as well, which is great. Who are we? So we're Health Innovation Oxford and Thames Valley, making a basic point that we are recording this session so we can make it available later. You can't be seen, your cameras and your mics are off until the question and answer period, so don't worry about that. And we will send out the slide pack after, so don't feel you have to write everything down. There's a bit of content, hopefully you'll pick it up as we go, but you get the slides and I'll give you some kind of pro forma templates that you can see afterwards as well if they're useful, just as kind of guidance stuff, okay? So as Health Innovation Oxford and Thames Valley, we've been around for just over 10 years, and we've been doing a lot of health innovation, as you'd expect, and we're mainly commissioned by NHS England and the Office for Life Sciences. We're all about accelerating adoption and spreading innovation, improving outcomes, experience and patient safety, and addressing health inequalities, and really saving the NHS money and delivering economic growth as well. So trying to get all those different bits together. We serve a population where we are for about 3 million people in Buckinghamshire, Berkshire, Oxfordshire, the Frimley health area, and Milton Keynes. We try to match innovations with identified population needs. We have mainly 4 clinical priorities, although we work other areas as well, but mainly cardiovascular disease, maternity neonatal, mental health and respiratory disease. And we're part of a national network. So I think some of my colleagues from other health innovation networks might be joining, which is great to hear and see from them. But we're in 15 health innovation networks around the country covering England. We are collectively Health Innovation Network. And we were set up as Academic Health Science Networks, AHSNs, back in 2013, when we relicensed last year until 2028 and renamed Health Innovation Networks. So each part you can see around the country. And we've got a decade of health innovation. Here's a few examples all the way through, things that we've done to help the system, to help industry, to help the NHS, and really to help patients to get the best outcomes that they can. So today we're going to talk about developing NHS business case. So it is specifically NHS, so there might be not one you've seen in a commercial setting before. It's going to talk about some of the things you have to do there around kind of getting NHS adoption and kind of understanding the business behind it. So the objectives today really kind of why you might need to write a business case or have a business case written for what you're trying to do. Who makes that decision once it's kind of produced, what's going to influence them, what sections to include, and some tips on the writing behind that. If you've done some of the or attended some of the 6 previous webinars, you'll see some of this content kind of building up to this. A lot of what you do with value proposition, a lot of what you do around kind of procurement routes and everything else is really kind of getting at what you might put into a business case. So what is a business case? I mean, there's multiple definitions out there depending who you ask. The Prince2 one, which is a project management methodology used in the public sector a lot, of which I'm a Prince2 practitioner, says it's really a justification for an organizational activity or project which typically contains costs, benefits, risks, and timescales, and against which continuing viability is tested. So quite succinct, but a lot of content in there. You can see it wants to have a lot of things included and weighed up. So really a balance between all of them. And what the NHS and public sector typically does is they test it against the do nothing or do minimum status quo position. Essentially, if we didn't do anything, what's the difference? So does this actually make things better? Will it make it the same or will it make it worse? And typically you want it to be better in some regard. So in savings, in patient outcomes, in safety, and something has to be better and sufficiently better to make the effort worthwhile. And it should be alive. When I say alive, it means You don't just approve a business case and that's it, you keep going. If something changes in the economics or the outcomes, you might have to then check it back again against the original business case, revise it and make some changes as you go. And if you've done research or grant applications, it's kind of similar in that you have to kind of justify, explain what you're going to do, what the benefit's going to be, but with a bit more of a commercial aspect, and commercial in the sense that there's money transacting here. It's not just a project going on its own, there's usually money being given, allocated or purchased from somewhere. And then why would you write a business case, or why would a business case be written? I should say more like it's really to just justify a decision for an investment or significant change. And you can say they're kind of interchangeable. So a significant change will involve people's time and effort, which has a cost to it. You need to receive approval for that investment or change. So you might be proposing something to a health system. If you're in a hospital yourself and you're working there, you want something different to change and happen. So this is a structured way of saying, I want you to agree with what I'm saying. Here's a justification for it, and to then give me that, either that approval to do it or the money to go and make it happen. And it could be for what we call revenue, which is kind of like running costs. So a new consultant or staff member, running costs around kind of how things are done, consumables, things which are small value items potentially, or what the NHS calls capital. Capital is kind of assets that sit on the balance sheets. That's new equipment or buildings, large machines, large buildings, things like that, or a bit of both. And simple definition, accountants out there, you might cringe. It's simply, capital investments sit on the balance sheet. They're assets and they get depreciated. So essentially, think of like a house. A house depreciates or appreciates over time, but it's large. You have an asset there. Revenue is kind of expensed when made and not depreciated. If you think like a house, the electricity or the gas you might use to heat or run your house, you really can't hold that as an asset typically. So it kind of gets used and you don't depreciate it. You don't say, oh, the electricity I used yesterday, I'll carry that, run that cost over. You just pay it as you come up to it, really. Same thing with kind of assets and revenue in the NHS. Here's an example that I've borrowed from the Oxford University hospitals. They are like many of the hundreds of trusts in the UK and England. This one is their business case initiation pro forma. Fancy way of saying it's a 4-page document that's really allows you to say, I want to do a business case. And I've got some basic details to kind of get it going. I'm capturing a few of those. And the key point to look at here is that it's a controlled and managed process. They don't want people writing business cases and expecting money to show up the next day. This one explains clearly it's the first step. It's not the only step. There are other steps depending how big it is. And if a proposal requires investment, an additional to agreed plan, so outside the normal budgeting process, with an estimated annual value greater than £100,000 revenue or is capital. So the revenue is 100,000 or anything is capital. So that's the distinction they need to be clear on that one. And as part of a project initiation meeting involves representatives of everybody coming around for that. And they really want a lot of quantitative analysis. So you might say lots of nice things. It's great. People feel happy about it. Someone really likes it, which are wonderful things to include. What they really going to want to know is how is it going to be paid for? What's the benefit going to be? What numbers are going to change? That kind of stuff. And they don't want more than 4 pages. So if some people like to go on, this is typical of most organizations that have to do this on a regular basis and have to justify public taxpayer spending. So they're going to use that. The next bits to it are the financial aspects to it. And typically this will be done with a finance team. So if you're contracting with the NHS, you'll have to get someone in finance or procurement who might be able to fill these in for you, or you might have some numbers yourself in that you're providing to the NHS. If you're within the NHS, you might need some of these as well. It's usually over a 5-year plan or however long the project's going to run. This one is kind of a 5-year one, looking at different things. So a budget, what they're expecting in the year, what's going to happen, the plans for future years, and they're looking at kind of income, the money that might come in because of this, paying staff, non-pay, the things around all those things that aren't pay, and what's the efficiency going to be? What's it going to contribute? That percentages, earnings before interest, tax, depreciation, and amortization. The accountants out there will catch me on that one. So essentially, that's trying to strip out things that might skew how you're looking at the numbers, and then non-cash releasing efficiencies, things that don't save cash, but they're other efficiencies. We'll get more things done, things like that. Benefits and then capital. That's a small one. That's just for a small case. So a really simple one. The next one is kind of a bit more, so what they call a simple one, a bit more detailed again. So looking at more and more stuff going in here, more posts, more people being brought in, more different items. And the last one here, which they use, this is all just for the kind of the initial part, is looking at really long detail. So activity, And then the NHS activity is the number of something that I do. So let's think of an operation. If I do a hip operation, one hip operation is one activity. And then WTE is what the NHS is a whole time equivalent. That is a fully employed person working 37, 40 hours a week. So 1.0 is one person, 0.5 is half of that person's role. And you're kind of adding them up to kind of come up to numbers and work your way all the way through. I will share the spreadsheet after, we'll send out later so you can see what's in this. There's nothing in it of any detail, so it's really just giving you a pro forma. But most NHS trusts will have their own forms that they'll want filled in for their own kind of internal purposes. And the finance or procurement or the person you're working with can help you explain, will help you understand that, and they can explain what's needed. You can do a basic one anyway, which you can adapt. That might be a good way to get going. And then who makes that decision? So you've done all this work, you've got kind of the basics in place, and the answer, it really depends. It depends who you're talking to, at what level. It could be a hospital, it could be a broader organization, and they'll have their own internal kind of financial controls. And it also depends on the total value of the proposal. So something small, relatively small anyway, if you imagine that, that's not going to be as big a decision as something that costs millions and millions of pounds. So the typical hospital trust model here, if you can read that hopefully, is that things under £100,000. You saw that initiation document a little bit while ago. Under £100,000, that's kind of within the division themselves. They can kind of make those decisions themselves. They're balancing their costs and their money coming in, money coming out. They can do that. It might be lower. Might be 10, 20, 50,000 pounds, depending how they structured that. Things over £100,000 is where you're getting into the formal processes, where you have to fill in the documentation, you have to get a board or a meeting to approve it and to document and minute that they made that decision to release that or to allow you to progress further. At the Oxford University hospitals, it's called a Trust Management Executive. That's a meeting of the board and the executives and most of the divisional chairs or divisional leads talking about that stuff. Things over £1 million, this is kind of a significant big one there. That's really kind of, that's where the trust board's going to have to make an approval. And above £5 million, this might be a bit dated now, it might have changed. NHS England or kind of a central body would have to approve that. And typically for capital things, they will want to know where the capital, what investments in buildings, things like that are going to be. Anything really large, you know, if you're building a whole new hospital, like the 40 new hospitals kind of program, that's going to be the Department of Health and Social Care and the Treasury needs to look at that, because that's really big money and that's long-term commitments. And the general thing is you can always get someone higher up to approve something for small, but you can't get someone small to approve something bigger than what they've got. Kind of makes sense. So the trust board could approve a £10,000 business case. They don't typically do that. Most trust boards have to approve any consultant appointments though, and they typically send them to royal colleges to get approved for the job plan and what they're going to do. And best practices is really, even if you don't need corporate or external approval, it's a good idea to consider what we've got here, just so you have the answers should they come up. If someone asks a question, you know the answer to them already. And generally, this is kind of human nature. It's easier to preach to those who already like what you're doing. So if you pitch the proposal to fit the organization's mission, so if you're talking to a mental health trust and you're doing something that improves mental health for patients, for staff, and generally is what they do already and they've said they want to do, you're more likely to get approval there, rather than trying to make them do something that's not typically what they do or is beyond how they usually do things. So address the mission and the priorities they've already probably put out in a report or a paper somewhere. That organization could be a hospital board, could be a clinical department, it could be an integrated care board or system, could be an NHS England body, one of the arm links body or kind of part of NHS England like a transformation directorate, or it could be a research grant making or other funding body or commissioner. So it could be lots of different people or organizations, but find out what they typically fund, and that's where you're more likely to be successful, rather than trying to find something brand new or a different category that's less likely to succeed. And those decision makers in those bodies, whatever role they have, they're going to have different concerns and you have to address them. And that's what the business case is going to try and do. They have to think of kind of the strategic context. Where does this fit in a political or health imperative? Are we really struggling with A&E? Are we really struggling, meeting, the number of mental health patients get referred to us or CAMS or something like that? What's the quality context? How are they performing now with the CQC, with their own internal kind of measures around how well they're doing that? What's the money like? The financial context is always important, has to be addressed in all cases. And there's less money than there used. Well, there's more money now, but it needs to go further. So there's always a financial challenge behind all that. And then performance context. When we say performance in the NHS, that typically means, performance against standards. So, or targets, some people call them. So it's 4-hour wait for A&E or 18-week wait for elective care. How are we performing against that? Or a 2-week wait for a cancer referral to a consultant. It's how they're performing against those. There are lots and lots of those, but if you can improve that, that's always beneficial. And those people will love you if you can do that kind of stuff. So if you think about what would make you invest or make that decision if you had to decide? That's kind of what I was kind of put in the back of my head or someone else's head. So you presented this and then look at it kind of objectively and say, have I put enough in there that someone's going to spend £100,000, £1 million of money they're responsible for? It's not money necessarily out of their own pocket, I get that, but it is money they have to account for, particularly for taxpayer or public sector money. So you really have to think about that. And the elephant's there just for a bit of fun to say people have long memories. So they're going to remember something that went through and didn't work. So if that's happened in the past, and proposing something similar, you might have to kind of answer that question about how's it going to be different or better this time. Equally, if they've done something really successfully in the past, they might like things that sound similar to that. So find things they like to say really great things about. And if you pitch something similar, they're most likely to be kind of happy with that. 5 cases model. This is something that's kind of used at kind of the large level for big cases, and it's looking at kind of these different things. So essentially a strategic case. So where does it fit against those large scale priorities? Is it needed against the aims and objectives of the organization? Economic case, is it value for money? That's the finances. Have they considered all that? Is this the best way of spending that money, delivering what we want to do? Commercial case. So commercial sounds a bit like economic, but it's slightly different. So is it viable? Can we actually go and get someone to do this for us? Is there a supplier who can do that? Or is there a way that we can procure this? If there's no way to procure it or buy it, you can't really do it. So they want to make sure that it's possible, or it can be done in the timescales necessary. So maybe you need to have a building up and ready for March 2025, but no one can build a building that you want in that time. So you kind of lost the commercial case there. If, however, there's something ready to go, possibly you can. Financial case, is it affordable? So what you're proposing to spend, can you get the money for that from somewhere? Either from earning it, from being paid to doing, health services, or is there funds coming from somewhere else that can help make that happen? And then the management case is really kind of think of it like a project management case. Is the organization capable of delivering that project? So either alone or with some external provider doing that. And do they have the systems and processes in place to make that happen? If you follow public sector kind of news, you'll see lots of things which sound great, but sometimes aren't delivered because of lots of reasons. Maybe the objectives weren't clear, maybe it wasn't delivered well for lots of reasons. So what you really want to do is assure them, make them happy that it's really going to be delivered with the best way going forward. And that's kind of what you're putting into those kind of cases. When we talk about income, so the way you're paying for this, there's different funding sources. So this is a model for an acute teaching hospital, but it's similar to a district general hospital, a mental health provider, anyone providing services. And this is kind of typically where they come from. So commissioner purchaser income, so commissioning intentions market. So NHS England, it might be ICS, it might be another organization that buys things from them. They will say on an annual basis, roughly how much of it they want done, how many procedures or things they want, how many people treated, and what they're going to pay for that. And they're also going to be looking at the demographics. So is the population growing? Are they getting less well, more well? Do they need more of one thing or another? Are prescriptions going up? Are treatments going down? They'll balance all that and do that on an annual basis. All the time between all these organizations, and there'll be commercial income to think of as well. So it might be some organizations will have histopathology, different leases, decontamination, non-NHS training, where they're getting money in for things that aren't just typical patient services, and they can maybe consider that. So you might have seen in the news different trusts working together on some of these kind of pathology things, doing that, and they can sell those services to others as well. Private patients, it's increasingly becoming there are more private patients being treated in the NHS. The other way goes as well. The NHS patients are being treated in the private sector, but a lot of NHS organizations, some of them can earn close to 50% of their patient income from private patients. They could be based in the UK, they could be foreign patients going for specialized services, but you need to be cautious there, assuming that insurers, kind of like your Bupas or your Avivas and AXAs out there, will buy something that NHS won't buy. So if for some reason the NHS isn't buying it, you might be you have to check that a private insurer would pay for that as well, because it might just be something beyond that. There's research and trials, so universities, government grants, private partnerships with pharmaceuticals or device manufacturers. That might be a way to get what you want in. So rather than having the NHS pay for it directly, someone else could fund it once you get all the approvals in place. Training income, that's so if you're a teaching hospital, you get paid to train people, rightly so. Students and things like people like that and services like that get paid for, and that's a way they get income as well. Another way to think of income is actually savings. It's a bit peculiar, but you think they're already spending £10 million. If you can save them so they're only spending £9 million, it's as if you've given them £1 million. So if you can find something that works really, really well, you can then say, we've now changed that on the income expenditure. We've got savings is really, really good, and they want to see that. So they might spend some money to save even more money. So it's a balancing out there. And the last one to consider, really, there's others potentially, but the other one is charitable funds. So for things that aren't typically bought by the NHS, either they're higher quality or they're not standard care or things like that, sometimes the hospital charity, most hospitals have their own charity, or there'll be other charitable sources might want to fund that. Think of a building for particular patients, maybe children, maybe cancer patients on hospital premises. The NHS can't afford that themselves, but a charitable fund or a charitable organization might fund that because it furthers their aims and is done in partnership with the NHS. They might be another source. There's lots of different options here, so I'm just kind of talking about a few. For commissioners, so when I say commissioners, I mean an integrated care system. So an organization that's responsible for a large group of hospitals or providers or GPs, primary care, and NHS England, for England at least, big things that cover, large regions or the whole country. And what they're going to need, at a minimum, is really evidence of clinical effectiveness. So it's the strength of evidence, likely magnitude of benefit and safety, and the number of people who can be expected to benefit from the intervention. So if you go to National Institutes of Health and Clinical Excellence, NICE, on their website, they've got spreadsheets that talk about this for different things, and they'll say how many people are affected by this condition, how many people could be treated on a yearly basis, what's it going to cost, is it really useful, is the evidence there to say it's really good to do this, as opposed to just not making a change. And they want to know what that impact's going to be on the population health. And when we say population, we mean like a whole region, maybe 10, 15, 3, 2 million, whatever number of people. And they want to make sure it's cost effective. So it's not too more expensive than it needs to be, but equally it's enough spent to make a difference and change. And they want to know what the cost is. Is it going to be an additional cost to them? Is it going to be a savings? Is it going to be neutral? And is it affordable? Typically, they want savings or neutral, things that don't cost more money, but achieve more ends. And they want to see what else is out there. So what are the alternatives? So in business, you talk about substitutes. What else is out there that could do the same thing? And they also want to support innovation. And innovation is a broad term, but essentially finding the best things that can be done, maybe differently to achieve the same ends, but better in some way or another. So different ways to consider that, who you're talking to. So it depends which organization you're talking to. Some innovators I speak to say the NHS, which is a very broad thing. There are lots of different parties and interested bodies within the NHS. You might have to pitch it slightly differently for different parts of it. So a clinician, a doctor, a nurse, a therapist in a hospital or a mental health setting or a primary care setting will have different interests than will the trust board or the integrated care system that works with them. General tips. Clear writing helps your case. So a typical point starts with a statement of fact, either given in the case or derived from analysis. And then that's the what, and then you make an interpretation based on that fact. So what? And then it leads to an implication, now what? So you're walking the reader or the person receiving it through a very clear kind of logic pattern there. Progressive logical thinking, it helps you make your point more clearly. So what? The A&E X-ray machine is broken. Okay, that's the what. That's a fact. So what? So we need to get an X-ray machine to diagnose patients presenting in the emergency department to meet the 4-hour standard. And without a machine, we cannot treat all those patients. Okay, I can understand that one. So now what? What's the next step? Well, now what? We need to purchase a new machine. So okay, we need to purchase a new machine. So the next question is you can think, how much is that going to cost? Can we purchase a new machine? What's wrong with it? All those kind of questions will come out, but you can see there is a call to action. There's some kind of urgency that something should be done about it. So that's a pretty clear one that would happen in a hospital. So you might be selling an X-ray machine. You might be selling the services to figure out how to do it, to put it in. All those kind of things. There's different ways that the NHS will do that, either with their own resources or by bringing in people externally. And generally, you want to develop from the general to the specific for ease of understanding. So you start really wide and then you've narrowed down into the point you're getting to. So the background material precedes the technical expose, which should lead logically to recommendations and conclusions. So I've said, here's the problem. I've said, here's what we can do. So I recommend this. And my conclusion is this. Most board papers want a presented solution. They don't want to just be left, they have to make up their own minds what to do. They like something that says, here's an option that we can do this. We can treat this many more people. There's really good funding. So I'm asking the board, or I'm asking this division, or I'm asking this, this person who can make a decision, please approve this for this amount of money, and it will be delivered in this amount of time. And everything that you see in there should support the recommendation and naturally lead up to them. You kind of want to walk them to that decision. So we want patients to have good quality care. We want to treat more patients. We want to do it economically. We found a way that we can do that with this new innovation, this new thing we want to fund. It costs this. Over 3 years, it will be cost savings in general, or about the same as what we're already spending. So pretty low risk, and you want them to walk through that. And you want to pitch it or have it written so that it's clear what you're trying to achieve. Be really, really clear on that first page. So like an executive summary. You've seen those before, or usually everyone's got an executive summary, that kind of one page or one paragraph at the beginning that really says what it is. We need to buy an X-ray machine to help meet the 4-hour standards in A&E. Here's why. How long it's going on for, what needs going on, that kind of stuff like that. Use understandable language. You might be dealing with really highly skilled clinicians or scientists, people who know lots of big words around that whole condition, but you got to be careful because not everyone who's going to be reading that or making that approval will be clinically trained or be a scientist with that background. They might be a finance person. They might be a divisional management person. They might be someone on the board who doesn't come from that background but understands business stuff. I need to explain acronyms. The NHS loves an acronym. People make up their own acronyms. There's some established ones out there, but at least the first time you use an acronym, write it out in full and then explain why that acronym is being used. That will really, really help. Main advice then generally is to match the case's length and detail to the level of investment or importance you're attributing to it. So essentially, if you've got a £10,000 project or business case, you don't need to write 20, 50, 100 pages. That's not necessary. As long as you can make succinctly and say what it is, that's probably an easier decision to be made. It may not formally need to be in writing. It probably should be. It doesn't hurt to do so, even just in a short version. The other thing is, whoever you're dealing with in an NHS organization, even though you've got a business case, which might be written beautifully with every word chosen, expertly, really need to get senior support early on. That senior management support could be a manager, or it could be a senior clinician in a management role. They need them to check your assumptions, confirm the way you want to do it, and you really want to get a key champion throughout that to kind of work with you. So the first thing that happens when I'm in the hospital, it used to happen when I was doing this, is if someone brought a paper and they took it to the finance director, or they took it to the head of the division to say, I want to do this in my department, what do you want to fund it? The first question they'll usually ask, either directly to that person or indirectly, they'll say, is the person in charge of that department aware of this, and do they approve of it? And if the answer is no, it's very unlikely they're going to take it forward. So you need to really kind of get that on board. There's no way to kind of within the NHS to jump it in most cases, unless there's a really big imperative externally. So it's unlikely that board management will push a proposal down onto services. So you can't go straight to the chair or the chief executive and say, make this happen. They could do that in certain cases if it's really, really urgent. What they'll typically do is they will ask the service what they think they need. They want them to work along with it to make it happen. And if a decision is going to be made, it needs to be recorded. This is a public sector thing. Probably most organizations have this as well, outside the public sector as well. It needs to be recorded in minutes with a paper that says, it was done by the right body at the right time. They said yes to go ahead, and they approved it in that timescale with that money. And they put it down in minutes, and they have the papers, and they're ready to show to an auditor or to someone else if they need to kind of check if that happens. So that's kind of the broad general things about how a business case gets developed and produced. If you've come on the earlier webinars, you'll see we talked about value proposition and some procurement routes and things like that. Those are all parts of what you might put into a business case and build it up. We will send out a kind of pro forma once you can see the information that goes into that and goes forward. There's a few more resources here, so I'm not going to go click on all these, but you can click, we'll send this out, and you can see them yourself. There's the NHS England scheme of delegation. Now, you may not want to look through it. You can look through that. The spreadsheet they've got in there, I think, is over 1,000 lines long, talking about all the things that NHS England can do. The point of putting that in there as a link was really to let you see that there's lots of people who can make decisions for different things. The one that might be useful, again, it might be a bit dry for some people, it might be really great for other people, is the Treasury kind of green book. Essentially, it says how they appraise and evaluate, essentially how they create a business case, what they're looking for, what should go into it, how the numbers should be made, and all that kind of information in there. Another link I'm putting in there is something the Health Innovation Network has recently launched, this thing called the Innovation Academy. It's currently hosted by East Midlands, Health Innovation East Midlands, and that is a place you can sign up for free, just with an email address. You sign up, it's got information, including about business cases, about all things we talked about in the webinars and other services and topics as well. Lots of Health Innovation Networks are putting information on there, so it'd be worth having a look at that. Looks really good, what I've seen so far. And the other bit we can look at here is what we've got ourselves, our innovation support pages and webinars around real world evaluation, health economics, data collection, and these webinars as well. So that's kind of the business case part. I'll take some questions in a second. I'm just going to kind of show you kind of the stuff that we've done over the last 7 webinars. So kind of a quick kind of summary slide from each one. So the first one was around developing your value proposition, which is just one slide from the whole presentation. This is what you look at. You can see how these will fit into a business case: market need, evidence reviews, stakeholder research, insight, strategy, essentially how it meets those. That's kind of what we did in that value proposition webinar. In looking at kind of developing digital products for healthcare, we looked at what is a digital product, where does it sit, all that kind of stuff, lots of information in that. Go back and have a look at it. The other one we did was around the NHS structures. So again, who's going to make those decisions? So you can see here, you might be coming down here at service provider level. You might be going to integrated care system level. NHS England, Department of Health and Social Care. So the bigger of what you're asking, the higher up you're going to have to go in that system. And then we talked about procurement. So essentially how they can actually buy things. We talked about procurement being the process of acquiring goods, works and services, essentially buying stuff. And the NHS spends a lot of money. They buy it from a lot of people, 80,000 suppliers. And of the £13 billion spent, about 25 billion of that is on frameworks, and more of them coming soon. We had a whole talk from Neil R. Armstrong about medtech regulation, understanding the US, the UK, and the EU, and kind of how it fits in there. So essentially, if you want to have something bought by the NHS, it needs to be regulated appropriately. They're going to check that. So you'd have that is the main kind of takeaway from that one. We then had a talk from Quiddity with Tom Cook talking about kind of market access in the NHS. I took one slide from his just talking about, the NHS is vast, complex, and interconnected. I think that's a nice way of explaining the NHS and the system here, with lots of barriers, but not barriers that are insurmountable. I think that was kind of the takeaway from that one. And we also had a talk about procurement from Nick Allen from Health Innovation Manchester, who helped us with that stuff as well. So generally, if you want help understanding NHS and stuff, contact us. Here are the contact details. We can do lots of stuff, as can the Health Innovation Networks as well. Real world evaluations, partnering on grant funding applications, data collection, report writing, health economic analysis, and links with local health organizations. So there, okay. So I don't know if there's any questions. I'll turn off the slides, and then we can go to taking questions, if that's okay. I'll just say again that if you've missed any of the webinars before, I mean, Rochelle has kindly put the link in there. So they're on YouTube, they're videos you can watch in your own time, usually either with external speakers or with us. And then if you attended or signed up for these things, we will send out the slides as well, so you can have them to hand. And if you're working with an organization, ask them what their template is they might be using, because it's really helpful to know how they're making those decisions. And that's not the only way they'll make a decision. They'll be using that as kind of the formal documented view of it. So the paperwork, there might be some decisions behind the scenes you need to be aware of. So how you engage the finance department, how you engage with the infection control or the information governance teams. These are all areas that things might happen that could slow down kind of the way a business case or a development or project gets progressed through. Oh, thank you, Bianca. I hope you enjoyed that. There's no questions. Well, it can be very quick. I'll stay on for a little bit if anyone's got any questions. You can also always contact us with those details in the presentation themselves. I think it's info@healthinnovationoxford.org. It's our general email address, but you can contact us or go to our website and find lots of information. And the Health Innovation Network, which is the group of 15 health innovation networks, has a lot of information available too. So not just from us, but from others as well, and working with other parts of the NHS system to kind of understand how things work and how they go.